There we go. Hopefully you can see my screen and that we've got people on the call. So I'm just going to give a few minutes just for people to join from the waiting room. Right, so we've got a busy webinar ahead of us. This is the fourth in the series of webinars sort of run by Cardiff University about issues around palliative care. So today's session, we've got a lot to cover. Sort of the title of it is End of Life Care in Patients' Homes and in Care Homes, essentially. So a lot to cover in an hour, and we've got a number of speakers today to help us sort of highlight the main issues. So we're delighted to have Professor Mark Talbot with us, who is going to talk to us about advanced care planning. We've also got myself. I'm James Davis. I'm one of the consultants with City Hospice, so community palliative care. Next to me, socially distanced, we've got Catriona Seed, who's one of the City Hospice clinical nurse specialists, who's actually doing an MSc in trying to improve care home education at the moment. We're also delighted to have Christy Wright, who's a district nurse, with ourselves. We've got a few technical issues. We're hoping to have someone from Hospice at Home as well, just to highlight what their sort of role is in looking after patients in the community at end of life. Just to mention, we're going to try and stick to an hour, but I know it's a lot to cover. So there's sort of a 30-minute session afterwards, which is the first hour will be recorded, but the 30-minute session afterwards, which is open to anybody who's on the webinar today to join, will not be recorded. There you can come and ask any questions you want, bring sort of cases along, but just to make sure that the patient and family members' confidentiality is sort of is kept, but that will not be recorded. So I'm sure there are probably some questions you may have from the main sort of webinar that you can bring along there, and we've got other sort of panel members there as well who will be able to hopefully give you some information. So I'm going to stop talking now and hand over to Mark, so to Professor Talbot, who's going to talk about advanced care planning.
Thank you very much, and I'm very aware of time, everyone's time, so I'm just going to launch straight in, if I can, share my screen. Here's my first slide, so that is already a very good sign that we're sort of off and running. So I'm going to talk about advanced and future care planning here in NHS Wales, and what we've done over the years. A bit about myself. I'm a palliative care consultant here in Cardiff. I've lived in Wales since 2004. And I chair the Advanced and Future Care Planning AFCP strategy group since 2018. You'll hear that mentioned a few times during my talk. For my sins, I must have been a bad person in a previous life. I have a lead role for DNA CPR in Wales. Not what I dreamed about when I was in medical school, but there we have it. Cardiff University diploma and MSc in palliative care I'm involved with, and I've got a teaching and academic role as well. So yeah, our strategy group here in Wales sort of oversees some of the issues around DNA CPR and advanced care planning forms, policies and strategies. We've got a terms of reference document if should you ever want to see that or join the group. We're answerable to the Deputy CMO for Wales and also the End of Life Care Board. It's a mixed bunch. We've got patients, we've got carers on board, we've got clinicians, charities, including elderly care and disability charities, and a fair few Welsh Government representatives as well. Initially due to meet every 2 to 3 months, but that really ramped up, as you can imagine, during COVID-19, because there was so much to discuss and so many issues and so many things to get right as well. I'm pleased to say that we've created quite a few national documents. And as you know, there's a national DNA CPR, but we also have a national advanced decision to refuse treatment document for Wales, which is really important. Also a record of best interest decision document and a statement of wishes and preferences document called RACPAP. Sorry about all the acronyms today, but it's a complex area. with too many acronyms, I realize that we do have to do a lot of jargon busting as well. That's where the patient and carer representatives helped me a lot. We also did a fantastic event organized in 2019 by Nikki Pease and colleagues, and some colleagues here as well, on future care planning, where we got lots of patient representation and carer representation and collated a lot of data around advanced care planning. And a lot of what you'll hear from me today is collated from that data. Now, you know, I've been a critic of DNA CPR forms in the past, including advanced care planning forms as well, but there's some very strong criticisms as well, more generally. So this was a recent, article from the Journal of the American Medical Association, saying that it's just too complex to do. It's really difficult to do, and the research, and the most recent research, doesn't support the whole practice of advanced care planning. Now, you'll be surprised to hear that I don't agree with this quite nihilistic notion of things, and I hope today I can convince you that there's a few areas that we can improve on, and perhaps our surrogate endpoints, how we measure advanced care planning, are perhaps not the most refined at the moment, because advanced care planning is not just about CPR, it's not just about making treatment decisions in advance. It is also about having more broadly conversation about dying, about death, and sometimes these conversations aren't had and they are avoided. But you'll see from some research today that I'll present that families, next of kin, friends are often grateful later on, especially during their bereavement or their grief, when they have had some time to prepare for the individual and being able to say goodbye. So there's lots of different aspects to this that are really important, and it's not just about a signature on a form. My interest started in 2015, where I was quite a vocal critic to the DNA CPR process and form. I got on Paul Buss's nerves, who was leading on it at the time, made lots of suggestions, and then he asked me to join the group. And then lo and behold, a few years later, I was chairing the whole thing. We've done a lot of work together as a big team, within Wales. We've created a lot of wraparound resources, which I hope, if anything, today you take away that perhaps there's some really good stuff to potentially have a look at. The collaborative NHS Wales have been really kind in hosting these resources now. And we also have the talkcpr.wales and talkcpr.cymru website, where we've made some videos for patients and for healthcare professionals to get some tips on how to hold these conversations, or what to do about thinking about CPR and DNA CPR. Pleased to say they're also available in the Welsh language as well, and also for people with hearing issues. So we've got a lot of wraparound resources, which I think is really important. You can't just have a DNA CPR form. You need a lot of the sources surrounding things. You'll see today that we were going to talk about some of the legal aspects, why we are where we are here today. And where the All Wales DNA CPR policy started was back in 2011, the case of Janet Tracy versus Addenbrooke's Hospital. The court case is really interesting if you get a chance to see it, and you can look it up online. But it made a few conclusions. So the ruling essentially said that patients should be consulted in relation to advanced DNA CPR decisions, save in exceptional circumstances, and that a person's Article 8 of the European Convention on Human Rights, to right to respect for private and family life, is engaged by the decision to put a DNA CPR form into someone's notes. And there, out of that came the sort of duty to consult. So we're supposed to consult. We're supposed to have these conversations with people to see what people's views are on it. You actually have to have a very good reason these days not to involve a patient in a DNA CPR decision and discussion. For a patient not to be consulted about a DNA CPR decision, the court case concluded, the clinician would have to consider that to do so is likely to cause that person to suffer physical or psychological harm. So the word harm is very important here in legalistic terms. Distress alone, well, we know these conversations are sometimes distressing and difficult and not particularly nice to have, but it isn't sufficient. You can't just sort of say, well, the person might get a bit distressed, I don't want to have that conversation, so I'll just put the form in the notes and I won't discuss it with them because they might get distressed. if that's all you're writing as an excuse in the notes not to hold that consultation, then that is insufficient. It needs to be physical or psychological harm, which we've interpreted and defined within the parameters as something more long-lasting. So very much long-lasting psychological harm from holding such a conversation, where the person is absolutely devastated by the conversation you've held with them, and they are really, really very harmed by it in terms of what you've said. And advanced DNA CPR decisions need to be made in accordance with a clear and accessible policy. Well, I'm talking about that today, but we do have a national policy in Wales, and so do Scotland as well. So both countries are lucky to have a national policy, which is regularly reviewed, and we're into our 4th version now. Yeah, and clinicians should be wary of being too ready to exclude patients from the process of having a discussion about this issue on the grounds that their involvement is likely to distress them. Many patients may find it distressing. This is what Judge Ryder said. Many patients may find it distressing to discuss the question whether CPR should be withheld from them in the event of a cardiorespiratory arrest. If, however, the clinician forms a view that the patient will not suffer harm if consulted, the fact that she might find the topic distressing is unlikely to make it inappropriate to involve her. I recognize that these are difficult issues which require clinicians to make sensitive decisions, sometimes in very stressful circumstances. I would add that the court would be very slow to find such decisions, if conscientiously taken, violate a patient's right under Article 8 of the Convention. And so from this, a lot of the, certainly anxiety arose back a few years ago in terms of the duty to consult and having to sometimes involve patients in these discussions when it feels borderline inappropriate to do so. If someone's really, really unwell, very elderly, very frail, and then to add insult to injury, you're telling them that you're not going to compress their chest and give them electric shocks. It's a big topic. And we've done lots in terms of education campaigns around this, including a public information campaign. And this article in The Guardian got a lot of traction, got a lot of feedback, negative as well, in terms of saying that CPR just often fails in the settings that we're talking about today. And so, if we as healthcare professionals don't know the figures and the numbers, what hope is there for patients and their representatives? So we sometimes need to convey this data, don't we? And if you just think, well, generally in hospital environments, when you have CPR, you might, leave hospital alive in 15 to 20% of cases. Okay, but let's break this down into further granular detail. Then you look at a meta-analysis which incorporated data from nearly 100,000 patients across 35 studies. And there you then find that patients with cancer that has spread had survival rates of just 1.9% of leaving hospital alive, as did patients with impaired renal function. So there's proxies for long-term conditions, including admissions for pneumonia, for instance, but also metastatic cancer, when actually your actual survival rates from CPR are very, very limited and very, very low. And so sometimes these figures do help a little bit when you think about how popular television sometimes portrays CPR successful in about 80% of cases. And so, yeah, our information campaign has not just focused on healthcare professionals, but we've also helped Which, the consumer website, write about this. Who knew that Which had a sort of section on DNA CPR and DNA CPR forms and advanced care planning forms? I didn't, but when they asked us to get involved, we've helped write it a little bit, and it's easy to get things wrong in this complex topic area. So it was good that they asked us. We've got a quite active patient liaison group as well, who've helped us along the way. And some of them felt strongly that patients need to sort of have information, good information campaigns get to them, so that they, in fact, may sometimes be the ones that broach it with their consultant or with their senior nurse, for instance, and talk about what happens towards the end of life. So yeah, we've got an open all access DNA CPR policy that can be read and accessed by everyone, as we should. And anyone involved in DNA CPR discussions and forums should have read the policy. That's really important. So you are able to then say, yes, I have adhered to the policy when filling it in. New forms of policy make it explicit that free text needs to be filled in to explain extent to which patients and next of kin have been engaged. I will say that, there's nothing worse than an absent DNA CPR form is a very incompletely filled in DNA CPR form, which leaves you with complete lack of confidence in terms of what discussions have been held and not been held. And 2 or 3 weeks later, even if I've just written in the free text section, I held a discussion with that patient about CPR and they didn't want it. That short sentence sometimes gives the GP or whoever else sees them next in an emergency situation potentially so much confidence to go forward and say, okay, this has been discussed. Okay, understood. Okay. And our policy, if you care to read it, it's a riveting read over the 30 odd pages. I really recommend it. Also deals with forms that come from St. elsewhere. So All Scotland DNA CPR form, what happens if one of those flutters in across the border, respect forms and various other things, and how we deal with that. All important documents, you wouldn't ignore them, would you? You wouldn't ignore a letter from an oncologist in Scotland saying a patient has malignant melanoma. So you also wouldn't ignore a form that comes with all those important discussions, documented discussions and instructions. Yeah, I think also important to record attempts to communicate with family members and Proxy. So even, if you're saying a care home situation or a nursing home situation and you've had a really important discussion and you think things may be quite imminent, even if you fail to contact a nominated kin or significant other for that individual, and let's face it, some people have very little in the way of significant others, and you've not been able to get through, document the amounts of times you've attempted to do so. There was the Winspear ruling where there was critiqued that doctors or clinicians hadn't actually documented their attempts to contact the individual or hadn't contacted them at the right time. Our Welsh Talk CPR communication approach elicits views on ceilings of treatment. So you don't just go in barging in with, would you want CPR? That's an inappropriate question anyway, but you can start small. You can sort of start saying, well, if you went to hospital, would you consider a blood transfusion? Are you someone who would care to have one of those if you needed one? Would you have antibiotics? Would you have that chemotherapy that the oncologists are offering? And you work your way up this sort of treatment ladder of approaches, and CPR can be at the top. By the time you reach the top, the patient knows that they're not being abandoned for all the others that are lower down the ladder, but might consider that with the low percentages of success rate for CPR, they might actually say, you know what, no, that doesn't seem quite right. And also remember, you're not asking the patient to decide, would you want CPR when you full well know that it wouldn't work? You're actually giving them a concerted medical opinion. You are a clinician, you've seen this before. You should be the one who advises the patient. And you should say, look, I really don't think it would work. All the other treatments, yes, let's give them a go. But I really don't think this would work. But do you disagree, or would you disagree with that viewpoint, basically? So it's a consultation, but you're not asking the patient or their family members even to sort of decide on, you know, the process of future CPR. And we've also written into the policy what to do if there's a difference of views. The concept of natural, accepted and anticipated death within 6 to 12 months being a trigger. And you can all find it on the wales.nhs.uk/DNA CPR website. So there's lots of links and resources there, including some top tips on how to start these conversations for healthcare providers if you feel a bit rusty. I sometimes feel rusty with my communication skills, and actually seeing, you know, the likes of the excellent James Davis consult occasionally might give me stimulation to approach things in a different way. So we all, you know, can learn from each other. And sometimes we just need a bit of a communication refresh. I think it's really important. If you want to see one of my approaches, then the treatment ladder approaches on the Talk CPR website and YouTube channel. Easy to find on YouTube. You just type in Talk CPR and search it, and it's all there. Here on the wards, we have the Talk CPR videos for patients and relatives. We printed out, and then say a junior doctor who's about to go in and may want to show the video can scan this QR code, gets straight to the video, and maybe we'll show the video to the patient after a bit of an introductory conversation. But, you know, certainly something that could also be done in nursing homes and care homes. And so far, no one has complained about these videos. No patient and no family has complained about them. actually, it's more empowering, and they feel a bit more aware of what's going on and what's being discussed. Always good to discuss DNA CPR or difference of views as a clinical team. If a patient says, no, I would want full CPR, and then the clinical team feel that it wouldn't work, it's not, then where there's difference of opinion, it's good practice to offer a second opinion. Okay, so don't just sort of say, no, we're just imposing it anyway. Get a second opinion from someone. And until then, our policy suggests to leave for full consideration of CPR at the point of arrest. Now, some people don't like that, but I think these are rarer circumstances, and I think it's important to sort of allow for that within the policy and to have those conversations with people. In some harder cases, we have been stricter and sort of said, no, we are placing the recommendation of DNA CPR into the notes. We're going to do this anyway because it's a clinical decision. You can appeal, and we've given them the ways of appealing against it, but it does remain a clinical decision. However, also it must be remembered that at the point of arrival of an arrest team or emergency team or paramedic team, paramedics, nurses, and doctors have the right at the time, in the absence of any DNA CPR form or advanced care plan, to say, no, we are not giving CPR in this circumstance. It takes a lot of confidence to do so and background knowledge, but they are able to do so. And we had to highlight that again during COVID as well. Recent CQC England inquiry looked at DNA CPR, found much evidence of blanket decision-making, in fact, but it found that a third of DNA CPR decisions had been inadequately discussed with patients, next of kin, and documentation of discussions was lacking. Also in England, there wasn't much national consistency with regard to policies and forms, and staff knowledge of what needs to be done was very patchy. Hopefully today, staff knowledge of everyone listening to this talk won't be so patchy anymore, and you've got a bit of a better understanding. And amongst the public, there was often a sort of perception that they would be asked to sign DNA CPR forms. And that, of course, isn't the case. It's a clinician who signs the DNA CPR form. There was also a very bad practice of writing things like learning disability or autism on top of DNA CPR forms, which, of course, these are protected characteristics. You cannot do that. And so lots of things came out during the pandemic. In Wales, for our All Wales DNA CPR policy, we have an equality impact assessment, which is also on the website. So it looked very much at the impact on people with protected, the 9 protected characteristics, and you can read that if you would like to. Also important to say that it's an approach, isn't it? It's sort of, if you go in purely with the agenda of CPR or DNA CPR, you may cause offense, if that's the first thing you discuss with a patient when they come through the door. Actually, a better approach, which we've worked on UK-wide, is the what matters most approach. And, you can address things like, it may seem strange for me to bring this up with you now, but you're feeling a bit better. Would you want to go through all of this again? Next time you were admitted, or next time you went into hospital, would you want exactly the same things again? And then a treatment ladder approach conversation can take place. The What Matters Most Charter, What Matters Conversations.org is a very useful tool to look at if you want some tips for conversation starters and how to approach the topic without seemingly being obsessed with CPR. And I think us healthcare professionals can come across like that on some occasions. This just from some brilliant local research. We're very lucky to have Anthony Byrne and Emily Harrop, who've done some great research working with national teams, and Mirella Longo as well. And they found that, surprise, surprise, there were risk factors for poorer end-of-life care experience. And one of those was not discussing the fact that death and dying were fairly imminent, and so some of these discussions should be held, and then DNA CPR can be a byproduct of them, but not necessarily the main focus. Again, a clip of one of the videos, talk CPR videos, to explain these things to patients. We've got the talkcpr.wales website, also the advancedcareplan.org.uk website, which explains the different aspects, complex aspects of advanced care planning to people. We've written things on cultural differences and approaches for people from, say, Muslim communities, for instance. Did you know, for instance, and I only know this because I've worked as chair of the All Wales DNA CPR group, that there's a fatwa on DNA CPRs, not a fatwa against me, or probably that will be next. But there's actually a published fatwa number 12086 that DNA CPR forms within Islam are an acceptable part of practice. And we've been asked this question before. So, it's all there if you care to look. This is what the website looks like. If you click on it, you can't now say that you haven't seen it. So the wales.nhs.uk/DNA CPR site also talks about the recent changes in November 2020 and version 4, what updates were in there. If you're dyslexic, then you might want to watch the video with me talking about the changes, summarizing those in just 10 minutes. Here's some of the key changes and clarifications to the policy. Also some pictures of the patients who've contributed to this policy. Audit, always good to do audit on these every 2 years in the different health boards. We're expected to do a DNA CPR audit, and this is the letter that I sent out, just reminding clinicians during COVID that not every patient in Wales is going to have a DNA CPR form who ought to have one, perhaps, but when there isn't a DNA CPR form or an advanced care planning form, then clinicians can still make a decision at the time where they arrive in the situation, a situational assessment of what needs to be done. And just the form itself, which you'll be familiar with, you may have not seen the latest forms, summary must be filled in for both patient discussion and next of kin discussion. Also a little update that HCPC number holders can now fill in box 5, and a few paramedics are already doing so, who are quite well trained and versed on the issue. On the back of the form, so that patients who get the form and take it home with them or hold it at home with them, they can then also have the web links, how to access the information, including the sharing and involving patient information leaflet. It's all there basically. So if people do want to find out more, all the laundry is being hung out to dry for people to look at. So there's no hiding. And we've got good advanced and future care planning resources on the wales.nhs.uk/AFCP website. I had an MND patient back in 2010 who lamented the fact that there wasn't an NHS or Wales advanced decision to refuse treatment form. Often my neurological patients want to make these legally binding forms. That form is more legally binding than any DNA CPR if it's filled in properly, signed by the patient and witnessed. And it's really important for treatment refusals that someone may want to make. So really important document that always needs to go at the front of the notes. I would even stick it in front of a DNA CPR form any day. So we have one of those as an all Wales approach, together with bilingual sort of guidance documentation as well. A lot of this informed by the conference that I talked to you about. Lady below who is standing is a lady with dementia who really contributed to the conference and helped us with some of the resources. This is what the All Wales ADRT form looks like. These are the Welsh guidance notes for all Welsh speakers out there. So we've got it in both languages, and the resources here. We've also got the statement of wishes and preference document. Now, that's not a legally binding document, but some people want to sort of put in writing something slightly softer. They want to work on it with their clinician or their CNS or the nurse that they're working with, and they might say, I never ever want to have a feeding tube inserted, or I never ever want to have this and this done. And they're able to then write this down, and we've got 2 options on the website. This is one of the options, the ACPA form that you can fill in, and has a lot of the information on there. This is something that we've worked on for quite a long time, the Future Care Planning document, and RBID, Record of Best Interests Decisions document, where we also, for it, actually got a full legal multidisciplinary review. Now, these documents often are made for people who lack capacity, and they sort of follow a sort of Best Interests Mental Capacity Act process. And so we felt it a good idea to get a full legal review on this document and the guidance notes, which we did, and we went along with their changes, basically. So this is a pretty good document. Again, it's not legally binding, but if you find this document, it will inform your practice and give you a good indication of what this patient may have wanted or may not have wanted from the evidence that is available. Finally, I just wanted to run you through the fact that there is in Wales, the message in a green bottle scheme, which has worked quite well. So ambulance and paramedics always look on the inside of a door to see if the sticker is there for the message in a bottle scheme. And they go to the fridge, they find the bottle, and they open the little bottle, and there's the advanced care plan or important notice or allergies or whatever are in there. Now, that's worked quite well on a number of occasions, especially for patients who live alone, who don't have a relative there who can say, here's the advanced care planning form or whatever. If you think that's a bit archaic, then we're working at the moment on an outline business case for an electronic advanced and future care planning solution for Wales, which will incorporate DNA CPR. It's a very, very complicated business, which I'm sort of leading on. It's making me lose the rest of my hair, I think, in trying to organize it, because it's so complex and we have so many different IT systems in Wales, and it all has to work for all of them, for all healthcare professionals who might access this documentation. We've written a little feature on advanced and future care planning strategic approaches in Wales, if you're interested. I wrote it together with a GP, just summarizing and highlighting some of the areas of importance there. And that's me. It's been a bit of a whistle-stop tour. I hope you found it helpful. And yeah, so thank you very much, everyone, for listening to me. My registrar is doing a MSc on virtual consultations. So if any of you get involved in sort of palliative care virtual consultations and want to sort of explain whether you find it easy or difficult, then she'd be really interested to hear from you. So feel free to do a quick scan of this QR code or get involved for this. James, have I stuck to time? Was it okay?
Thank you, Mark. I would a little bit over, but that's absolutely fine. I mean, it's a huge topic to cover, and thank you so much for joining us today. I think there's, I'd expect there's probably some questions that people may have, and I think the half an hour afterwards, I think would be a really good forum to be able to ask those questions, because there's a lot of, it's a bit of a minefield, isn't it? And if it's something you do on a day-to-day basis, you take it for granted, but actually it's not straightforward. And I'm going to go back and I'm going to soundbite that bit where you bigged up my communication skills. So thank you, Mark.
Always something to learn from you.
Good or bad, right? Thank you, Mark. So as I say, if there's any questions, then if you sort of stay on afterwards. Right, so myself and Catriona are now going to just go through briefly sort of the practical aspects of end-of-life care at home and in care homes, and there's a huge overlap. Hopefully a lot of what we're going to discuss today is going to be a repetition of themes which have come up in the previous webinars. So hopefully a lot of it is just recapping. So this is sort of what I was planning on covering. These are sort of the essential things that for myself and Catriona that you need in place. So first of all is actually what does the patient, what do their loved ones, and I put loved ones, not sort of family, because that could be anyone closely involved in their care. What do they understand about what's going on and what are their expectations? Obviously, Mark has covered in length about the advanced care planning, but just sort of to highlight a couple of brief things there. About symptom control, about care and equipment and the practicalities of how you get that in place. And then what we do, the conversations that we have here around sort of the last hours and days of life, and really who to call, sort of a bit of Ghostbusters, who you're going to call. And then I'm not going to go into too much detail about what to do after death, because the next sort of week's webinar is around that. This is a slide that has come up a few times, and it is an oversimplification of a complex issue. But for us to plan for end-of-life care, I think first of all we need to recognise that it's coming at some point. It's obviously coming for all of us at some point, but there are triggers which then mean that we need to think about planning for this. And that's not just the advanced care planning in terms of the document; it's the practical things and the other things that we'll talk about. But it's looking at how broadly, depending on what sort of illness somebody has and what sort of general condition they're in, what are we thinking in terms of prognosis, and can we try and get our crystal balls out and predict what might happen and what we would do in those situations? So I think we've touched upon this before, but prognosis is for some patients and family members that's important, and usually they've got practical reasons why that's important. But I think as healthcare professionals, it's important for us to in our head to have a broad idea of what we're thinking in terms of prognosis, because if we think prognosis is very short, then we need to get things in more quickly. But any sort of time frame is a guide only. I think Dr. Hayes, so Joe spoke about this last week, but this is what I use, that if we're seeing a deterioration month by month, then the prognosis is likely to be month, week by week, weeks, day by day, days, etc. That's assuming that we can't intervene, that there's not an acute issue, or that they don't have for example, a cancer which potentially systemic anti-cancer treatment is going to significantly extend their life. Then that's a broad way of thinking about prognosis. But if someone is starting to deteriorate more quickly, because usually what we see, and going back to the last slide, is a sort of an accelerated deterioration when someone is approaching the end of life. We can't do anything about this, then that person is approaching the end of their life, and we need to try and get these things in, the practical things, but also the advanced care planning done. So the first sort of point I think is really important is, and this sort of touches upon a lot of the things we talk about, including advanced care planning, is actually what does that person, that patient, and what do their loved ones understand about what's happening, and what are they expecting? Because if you're thinking, oh, this person is probably in the last weeks or days of their life and there isn't anything we can do, and they're thinking, well, I've got 10 years to live. If you start talking to them about resuscitation and where you want to be at the end of life, then actually they're gonna not understand the importance of that, and probably potentially ask you to leave, because they're thinking, well, why are we talking about this? So if there's a big information gap there, the first step, and when I'm seeing someone at home, the first step to trying to make some decisions around advanced care planning is actually you all being on the same page. And that includes everyone involved in someone's care, the patient and their loved ones. And to do that openly and honestly, obviously compassionately, but I think to not sugarcoat things, to certainly not give false information, and to give information to patients that they want. So if someone asks me, how long have I got? Usually I'll ask them why they need to know that, because usually it's practical things, or they want to sort out a will, or sort of financial things which would be something that we can help with. But if somebody's asked that question, they want to know the answer, then I think I've got a duty to be honest with them. But we don't know what the future holds for patients we look after. So I think it's being honest about the uncertainty and the unpredictability of what potentially could happen. But I think it's, again, being honest that if somebody is approaching the end of life, and someone is dying in the last hours or days of life, is to be honest and clear about that with somebody. So obviously Mark has spoken about advanced care planning, and I'm never going to be able to match Mark in terms of discussing that. But ideally, we want to try and at least offer the advanced care planning a long time before what we would call, the last sort of days or short weeks of life. I think just on a practical level in the community about the DNA CPR form is thinking about, as Mark spoke about, actually it's a medical decision. So somebody can't demand CPR, but at the same time, there is a practicality in the community. If somebody's up and about and doesn't want a DNA CPR form in their house, it's hard. You can't just leave the form there. So it's then a negotiation. So it's slightly different to in hospital. But if I'm seeing someone who's deteriorating significantly, I generally ask myself two questions. Number one, is there anything I can do to intervene here? And is there anything reversible that can be done? And usually that would need the relevant healthcare professional. For us, that's usually sort of a GP or secondary care professional to review. Is there anything that we can do to either slow down or reverse this deterioration? But secondly, I think, and really importantly, should we intervene? So what does that person actually want? And that's the whole point of the advanced care planning, is it's not just about getting forms in place. It's about generally what does that person want? And also is what's the realistic outcome from this? Because if somebody's deteriorating rapidly from a cancer which we can't treat, they've now happened to have a chest infection on top of that, but they've said they want to be at home at end of life. I'm really thinking, well, is going into hospital really going to alter this? No, what's going to happen is they're probably going to die in hospital, so not the right thing. So it is muddy waters, but I think we need to try and be in our minds and with patients as clear as we can be. If somebody's got a clear wishes in terms of advanced care planning, then we try and follow that. But I think it's often useful to have a plan B, because somebody says they want to be at home at the end of life, and then their decision or things are different to how they imagined it, or there are difficulties which we didn't sort of envisage, then it's useful to have a plan B. I put there that end-of-life care, if somebody's at the end of life and they don't want to go to hospital, usually we need a DNA CPR form in place. And for me, that's usually, so I put it to patients and family members, it's a protection against going into hospital and having something inappropriate done. And usually people are fine with that. So symptom control, I think this has been touched upon in the previous webinars, but what we're talking about in end-of-life care is just in case or anticipatory medications, and thinking about generally what we would call the 4 A's is what we teach. So it's an analgesic, an antiemetic, an anxiolytic, an anti-secretory. Usually the analgesic is usually a strong opioid. The antiemetic, I think Joe touched upon in the last sort of webinar, but generally cyclozine, metoclopramide are the ones we tend to see. Midazolam is the injectable anxiolytic we usually use, and hyoscine hydrobromide or sometimes glycopyrronium, usually hyoscine hydrobromide, and those are sort of your just-in-case medicines. But I think it's important that any prescription should be individualized, and we need to take into account any medicines that are already on. If they're on high doses of strong opioids, 2.5 milligrams of morphine isn't going to do anything. So I put there just some links to guidance in terms of prescribing and just general guidance about approaching end of life and how to look after somebody at the end of life. So those links are in there. I think we can probably make them accessible to people. One of them there is the care decisions for the last days of life guidance, which has got a really nice section on symptom control and also on sort of management of diabetes and things at the end of life. So a really useful document that if you look after people at the end of life is probably worth just having to hand somewhere. Care and equipment. I mean, if we're seeing a gradual deterioration, ideally we're getting things in place before they're at crisis point. And at the moment, it's really difficult getting care and equipment in place just because of COVID, Brexit. The world in general is just, it makes it more tricky. If I'm going into someone's house and they look like they're imminently dying, it's the first time I've met them and they're staying at home, the bare bones is sort of ideally a hospital bed, which can be ordered quite quickly, or a repose mattress, so like a Lilo, which goes on their normal mattress, glide sheets to be able to move somebody, pads for continence, ideally things like toilet aids if they can get out on the commode, and things like a bottle, but not an absolute. And then care. So if somebody's rapidly approaching the end of life, then we usually put in a fast track care, which is done by the district nursing service. They do the assessment and the relevant referrals. I put, and I may get shouted at by Christy, our district nursing colleague here, because I may be, if I'm wrong, apologies. But in my head, if somebody's got sort of 1 or 2 days, looks like they're imminently dying, then it's a fast track 1, fast track 2, normally around about up to a week in terms of prognosis, so still deteriorating rapidly. Fast track 3 is under review, so whether that continues or not is not completely clear, but normally up to about 3 months. But there is provision for care. If somebody's deteriorated very quickly, then it's picking up the phone to the district nursing team to see about a fast track assessment. And if somebody is in the last hours or days, I think speaking to the family about what's happening, and again being clear and open about what is happening, unless obviously there's inappropriate medication being prescribed, which I'd hope not, people become more sleepy, they become less communicative, and I think it's just reassuring families this is a part of the dying process, and that people are eat and drink less. usually sort of artificial means aren't appropriate, and there's no clear evidence of benefit at the end of life, and actually some benefit that it can cause side effects. Also talk to people about chest secretion, so often colloquially called a death rattle, which obviously isn't a nice term, but family members, if they've never heard it before or not expecting it, it can be quite distressing and worry about sort of family members drowning and things. So it's important just to explain to them that that can be a natural process, and we've got medications that can help with that. And as long as the person isn't aware of them, it's not going to be distressing. And then so this is just a very brief who to contact for support. So if there's an acute new issue with somebody, then actually they probably need a review. They need a review either by their GP, out of hours GP, if they're known to an oncology team or say a heart failure team, and it's appropriate that actually that would alter their management, then that should happen. Again, if they're acutely unwell and there's somebody who's for full active treatment, then potentially it's 999. But if we're seeing somebody deteriorate and they need symptom control at the end of life, immediate symptom control, those injectable medicines are generally given by the district nursing team. And then if there's ongoing issues, then obviously the palliative care teams, relevant palliative care teams in Cardiff or the Vale would want to know and review that. And then there's a number for out of hours, which has recently changed to 111. So those are sort of just useful contacts. Then after death, I think it's important to explain that there's no immediate rush, and that family members can spend time with that person. The death needs to be certified. So there are some district nurses, I think, who can do that, but in general, it would either be the person's GP in hours or the out of hours GP to come and certify the death. They can contact the funeral director, and usually there's either that funeral director or will be a reciprocal arrangement where there's sort of a 24-hour service. It would be the usual GP who would actually issue the death certificate. The out of hours don't complete death certificates at all. And going back to what Mark said about sort of religious and cultural needs, certain religions, off the top of my head, sort of people of Muslim faith or Judaism would need to be buried as soon as practicable. And there is a registrar who works in City Hall from 9 till 12 on the weekend, and there's a mobile number there. But the rate limiting step is actually they need a death certificate, and you can't issue a death certificate until someone's died. So, but it's useful to know that if you have got a death certificate, someone can have a registration over the weekend. And I've had a patient recently where we've managed to do that. So I'm going to pass on to Catriona, my colleague.
Hello. So I'm just going to cover in a little bit about particular care and care homes for end of life. So a lot of it we've already covered, so it's just specifically what we're doing here. Again, it's about patient and family understanding and expectations. So the most important thing is going to be timely communication between nursing staff in the care homes and the patients and the family. Again, advanced care planning, so exploring end-of-life wishes, making sure you've got things like your anticipatory medications and discussions about resuscitation ahead in a timely manner. And obviously, if you are noticing any deterioration with the patients, you need to be having these conversations very quickly so that you can inform families or the people important to them in a timely manner. I think the most important thing is not just to make sure that you're having these conversations, but making sure that you're documenting clearly that you're having these conversations. I know a lot of nursing homes have different places where they document this. And I think it's just making sure that things are clearly handed over to staff. So any communication that you're having is very clearly documented, especially if you've got, say, agency staff coming in, or you've got an advised GP coming in to have further conversations, is making sure that any established wishes are already very clearly documented. Okay. Thank you. So we're just going back very briefly to the advanced care planning form. So this is the one that you can use if someone's got capacity to make decisions. So this is available on the NHS Collaborative Wales website, and there is guidance on completing it as well. It's not legally binding, but it does allow someone to explore any wishes that they may have about where they may want to be for the end of life care, but also any potential ceilings of treatment. And that might include things like whether they would want to go into hospital, whether they would want to have feeding tubes or anything else of that manner. You don't necessarily have to do this form, but sometimes if people have very particular wishes, it's a really helpful form to have. So it's something that's worth having a look at to see if you can get quite familiar with it. Okay. This is another form that we use. So there is the record of best interest decision form that Professor Talbot did touch on. This is something we find much more helpful in the community. So it's a treatment escalation guide, and it's something that we use for patients who don't have capacity to make decisions. It's ideal if you can get as many people involved in the conversations when you're completing this form. And it's a way of exploring potential circumstances and scenarios about potential limitations and ceilings of treatment. So it's not just about a blanket, are we keeping people at home for end-of-life care, but it is potentially exploring areas where it may be appropriate for them to be admitted to hospital or any other ceilings of treatment. Again, there's guidance on completing this form, and if anyone needs any advice, you're very welcome to contact your palliative team as well to see if there's any, if this would be helpful. Okay.
Thank you, Kat.
So the main thing is obviously 9 times out of 10, people with advanced dementia find it distressing being in hospital. They may not benefit from hospitalisation for reversible causes, but it's not the case all the time. So we don't want, as we say, the one shoe fits all. We need to look at the individual and the person. And that's where having these conversations in a timely manner is really helpful. Again, as James has touched on and as Mark's touched on, having the conversations earlier when people are more well is much more helpful. It generally causes less distress overall to the person and the people important to them to have these conversations, and it allows people to plan ahead. Okay, so having these conversations about what they may want as they get less well is really helpful. Good communication is vital. Okay, taking the time to sit with the person, with the people important to them, make sure you've got a calm space to have these conversations and giving them the time to ask any questions that they may have is really important. Okay, allow them to ask questions. If you don't know the answers, that's fine. You can always go away and get them, but it's better to be open and honest. And the key word is sensitive, because this can be very distressing. Make sure you document everything that you have, particularly in the care homes, and make sure it's all very clear for any colleagues. Only other thing I will just briefly touch upon is regarding artificial nutrition and hydration, which is something that we don't routinely do for someone towards the end of life. Normally when someone's approaching the end of life, their body's trying to shut down in effect, and actually by artificially trying to hydrate them, you can sometimes cause more harm than good. We don't usually see much evidence that there is a benefit from it. But again, it's something that needs to be addressed sensitively with the family. Okay. If you do feel that someone's in the last days of life, then it's about using the All Wales guidance care decisions for the last days of life. It's available on the website NHS Wales. And if you're one of the nursing homes in my project, you should have some in your nursing home available. It's a great document. It's there to help guide care. There's lots of supplements that go alongside it that talk through how to use it. Also, as James has touched upon, about symptom management as well. So it's really helpful. So please do make use of it. And again, if there's any questions, do come back to us.
No, it is a great document, a really good document. Just going to move on now to, it's Christy, who's one of the district nurses in the Vale, who's kindly agreed to say something about district nursing involvement in end-of-life care, because we're always talking about them and they're so important, but it's really important to get their take on things.
Okay, can you hear me? Hello?
Yeah, great.
Can you hear me?
Yeah,
good.
lovely.
Can you see my slides?
No.
Not yet, no.
Okay.
Shall I share them for you, Christy?
Yes, please. Yeah, for whatever reason. I'm not very good at IT, so I'm sorry, everyone. Thank you. Okay, cancel that. Okay, let me know when you're ready. Okay. Okay, so hello, my name is Christy and I've been a district nurse since 2020. I wanted to highlight the vital role that district nurses play in end-of-life patient care in the community and some of the challenges that we face. The district nurse's role is to be there for, oh, next slide, please. Sorry, thank you. The district nurse's role is to be there for the patient and their loved ones, to care and support, to inform so that they can make ethical care decisions before and after death, to talk about what to expect and what to do, to reassure, and most importantly, to listen. We work hard to build an open, empathetic, and supportive relationship. Some patients we will have known for some time, whereas others we will only know them through their end-of-life care. We carry out in-depth, holistic nursing assessments of their end-of-life needs, covering pain, nausea, breathing, psychological, elimination, skin integrity, oral care, and spiritual aspects, and will constantly reassess these as we care for them. We are often the first point of contact for the patient and their family, and are available 24 hours a day to care and be there for them. We will help with symptom control when there is pain, sickness, shortness of breath, or a cough, fear and agitation, breakdown of skin. We will go out as quickly as we can to assess, administer PRN medication where necessary, and manage syringe driver administration. We will provide wound care for patients with chronic fluid retention and care and equipment for pressure ulcers if the patient's skin breaks down. District nurses organise end-of-life medication and prompt dose or medication changes. We reassure, care, and offer comfort when we are needed. We will do all we can to achieve a good, peaceful death for the patient. District nurses will often be with the patient and family just before, during, or just after the patient has died, and we will carry out a bereavement visit to offer support and signpost families to bereavement organisations. District nurses help arrange fast-track status assessments and refer and organise the care plans for hospice at home care for the patient. We arrange home delivery and collection of care equipment and refer to other health and social services where needed. We work closely with Hospice at Home, Marie Curie and GPs and coordinate the holistic person-centred end-of-life care plan. Apart from carers, district nurses will often spend the most amount of time with end-of-life patients and their families, and we will have quickly built up a strong professional relationship. Our goal as district nurses is to reassure them that they are not facing this sadness alone, that we are there with them. Next slide, please. So the challenges. End-of-life care may lead to crisis situations for the patient and their loved ones. Examples include families who want to care for their loved one, decline all care support, and then burn out. Due to COVID, patients have been self-discharging too early and returning home with no support. Family and patients who are in denial and unable to comprehend the prognosis. Another challenge is dispelling the myths about end-of-life medication. We have experienced family members stopping a syringe driver because they feared it would shorten their mother's life. The emotional impact can be really hard. We have recently cared for a young woman with brain cancer who had young teenage children, which was really tough and upsetting for the team. Like many other departments, our service is really busy and there is no time to decompress whilst on shift. Managing difficult conversations with patients and their families, knowing what to say, how much to say, and the need to adapt this for every patient and family member, and often being asked, how long? We care for patients in their homes with their family around them. Home environments can be tricky and families can be very complicated. Patients and relatives may have completely different wishes and expectations for their end-of-life care. Not having enough time or enough staff. The reduced night team cover all Cardiff and Vale and may have to travel up to 30 miles across the city to visit palliative patients. District nurses are not an emergency service and we do not hold stock of everything or every dressing. Communication between the MDT and agencies can be difficult as we are all under pressure and very busy. Urgently needing to speak to a GP can be really hard, or visiting a patient to find out they died the night before and no one has told us. District nurses waste many hours sorting out incorrect or poorly written medication charts, which is especially challenging at weekends with a reduced team of nurses, or going to set up a syringe driver prescribed by an out-of-hours team, only to find out that the out-of-hours team has now decided against it and forgotten to tell us. Please keep us informed. It is really important to make sure that the correct medication is prescribed correctly on the correct community chart. Us working together and getting it right does make a massive difference. As one mother wrote to us, "For you are giving a kind, caring, compassionate service to people at their most frightening, fearful and vulnerable times of their lives." And as a district nurse, I feel most proud of the end-of-life care that we give to patients and their loved ones. Thank you very much. Do I just stop it now? Thank you.
Right. Chrissy, thank you so much for talking. I think we talk so much about district nursing, you know, district nurses do this, district nurses do that. That actually, I think it was really important to have you come and say those things and the challenges that you face, and actually the things that can just make your job easier or just more straightforward, because as you say, you were very much on the coalface with with patients at the end of the life. And we at City Hospital work really closely with district nursing teams and with GPs, and when I speak to families and patients, that's what I say. So I think that's great to hear that, to hear how rewarding it is, but also how the challenges you face. So hopefully people who are involved with interacting with you will take that away, and I certainly will as well. So last but not least, have we got someone from Hospice at Home on the webinar?
Yeah, I'm here,
Right.
James.
Right, I'm going to hand over. Is it Sian?
Yeah.
Yeah, lovely. I'm going to hand over to Sian now from Hospice at Home.
You just have to bear with me because I'm not very good with Zoom. Right. Can you see that?
We can see you, but we can't see your presentation yet, Shah. If you click share screen.
Stop that a minute. There we go. Is that showing now?
No.
No?
No.
Do you want to
No.
send it to me, Sean, and I can show it? It's Joe.
Yeah, I just gotta work out how to stop it. Sorry, guys. Zoom is not something I ever use. And slide. It's only brief. Do you want me to share it, or it's just a couple of slides? That's all.
I mean, maybe Shadi, maybe if you're happy to send it to Joe, and then if you start talking it through, and then Joe can get it up when it's ready. But
I think Joe's got it already, so she could just share it, and then you could talk to it if you wanted to.
Yeah.
Have you got it already, Joe?
Only if you sent it to me or somebody else did. I don't know that I have.
No worries. Let me. Bear with me. Sorry. There we go. That's the right one. No. Send. I don't know how to stop sharing my screen now. Sorry, guys. So sorry, yeah. So I'm Sian, one of the clinical nurse managers for Marie Curie, and oversee our services across the southeast of Wales. And in Cardiff, we have got our Hospice at Home service, which, as Christy mentioned, we work very closely with the district nurses in that service. We accept, sorry, I haven't got my PowerPoint to follow the points, apologies. So we are, have you got it, Joe? I might wait for you because I'm losing my track of train of thought there.
Got it now.
Fab, thank you, Joe. Am I still sharing my screen? Yeah. Thank you, Jo. Okay, so obviously, so we cover the whole of Cardiff and the Vale. And our criteria for our service is that patients must be deemed to be a fast track, either 1, 2 or 3. We generally prioritise the fast track 1s and 2 to ensure that we always have sort of capacity available for those patients when they need it most. We deliver care to patients either within their own home, but we also go into residential care homes also if support is required there. We were, as I say, all our patients that are referred to us need to have a named district nurse for us in order for us to be involved with their care. We accept referrals from district nurses, the clinical nurse, palliative clinical nurse specialist, and discharge liaison nurses from the hospital. As of the 4th of April, all our referrals will only be accepted from the new referral form that we've been trying to cascade across the health board and encouraging referrers to use. And we are always looking at reviewing those patients who are sort of on our caseload and stuff. So if we're coming up to the 12-week mark and patients are quite stable, we liaise quite closely with the district nurses to get reviews of the patients done and looking perhaps for a more appropriate service to meet their current needs. Alongside our multi-visit service as well, which is a double-handed run, we always offer on an ad hoc basis a night respite service to allow people overnight to have some respite, knowing that there is someone there with their loved ones. So should they need anything, there is someone there to tend to their needs, to allow them to have that rest they need to continue in that carer role and to avoid any burnout or unnecessary sort of hospital admissions, really. And that is sort of a whistle-stop tour of our Marie Curie Hospice at Home service in Cardiff.
Thank you, Sean. I think it's, you know, when it's available, it's invaluable for patients and families, because I think what we find is at the end of life, often the things which are most difficult is the caring aspect. So thank you very much. I want to say thank you to everybody who's spoken today, and thank you for everybody who's been on and stayed on the webinar. I realize it's run over, but I think there's been a lot to cover, and hopefully some useful things that we've discussed. There'll be now, if we stop recording.